Oxygen, the most important gas used for medical therapy. Other gases used for medical therapy are helium-oxygen combination known as heliox and nitric oxide. Now, what are the indications of oxygen therapy? Oxygen therapy is indicated in adults when the arterial pressure of oxygen decreases below 60 mmHg or the saturation decreases below 90% on room air. In neonates, the figures go little down to be less than 50 mmHg for oxygen pressure and 88% for oxygen saturation on room air, or the capillary oxygen pressure less than 40 mmHg. The main aim of oxygen is to prevent or to correct tissue hypoxia. These are the indications of oxygen therapy. Respiratory failure, either hypoxemic or hypercapnic, acute asthma, acute myocardial infarction without respiratory failure, normoxemic hypoxia, perioperatively for the prevention of surgical wounds, post-operative state, before tracheal suction and bronchoscopies, and finally in cluster headache. In acute asthma, the aim of oxygen therapy is to protect against hypoxemia resulting from pulmonary vasodilation following the use of beta-2 agonists. And of course, it's indicated if hypoxemia is already present. The third indication is in the presence of forced expiratory volume 1 or peak expiratory flow rate less than 50% in the absence of oxygen monitoring, which is difficult somewhat today. In acute myocardial infarction, oxygen therapy has the following values. Hypoxemia may develop due to VQ mismatch and excessive lung water. Second, the use of nitroglycerin will dilate the pulmonary vascular bed and increase ventilation perfusion abnormalities, and this will lead to hypoxemia. However, this occurs for just 2 to 3 hours, and this is time enough to use oxygen in them. For uncomplicated cases of myocardial infarction, excessive administration of oxygen will lead to systemic vasoconstriction and maybe hypoventilation in COPD patients. So, it's not advised to give more than 40% inspired fraction of oxygen. However, in complicated cases of myocardial infarctions, for example, by heart failure, oxygen requirement is guided by the arterial pressure oxygen monitoring. Another important indication of oxygen therapy was called normoxemic hypoxia, a condition in which there is tissue hypoxia but the arterial pressure of oxygen is normal. Examples of this are acute anemia, carbon monoxide poisoning, and sickle cell crisis. And by the way, for carbon monoxide poisoning, hyperbaric oxygen therapy is indicated rather than oxygen at ambient air. Post-operative state. Following surgeries, there is increase in alveolar arterial oxygen gradient and decrease in the function residual capacity. This will lead to VQ mismatch, which may progress to shunting. However, in peripheral surgeries, this problem persists just for a few hours. However, this problem is significant in elderly patients, in obese patients, those with cardiopulmonary diseases, and patients subjected to thoracic and upper abdominal surgeries. In these patients, oxygen therapy post-operatively may be required for up to 2 days. Now, what is the end point of oxygen inhalation? Simply, it is satisfactory increase in the arterial pressure of oxygen or the saturated pressure of oxygen. Increase in the arterial pressure of oxygen during inhalation is not an evidence of increased tissue oxygen availability. Simply because oxygen has a tendency to reduce systemic blood flow. Now we're going to talk about the oxygen therapy devices. The performance of the devices depends on several factors. Number one, the type of the device, either mask or cannula. The flow rate of the device, 1 liter or 10 liters. Fit of the device, inspiratory flows of the patients, respiratory rate, and tidal volume of the patient. Oxygen therapy devices are classified into low flow and high flow. The low flow are called variable performance equipment. And these include the nasal cannulas or bronchs, the nasal mask, the simple face mask, or the classic mask, or called non-reservoir oxygen mask, and finally the reservoir mask, either partial rebreather or non-rebreather. While the high flow or fixed performance equipment include the anesthetic bag or bag mask valve systems and the venti mask, or what's called high airflow oxygen entrainment masks. The nasal cannulas or nasal bronchs has small reservoirs about 50 ml, and though there is no risk of carbon dioxide rebreathing when using very flow, 1 liter. In general, the nasal cannulas use flow from 1 to 5 or even 6 liters per minute and no more, with FiO2 beginning from 24 up to around 4.4 or 0.5. More than 6 liters is not tolerated. Nasal cannulas are suitable for mouth breather patients. Oxygen should be humidified when I use relatively high flow from beginning of 4 liters. The advantage of nasal cannula mainly its use easy and is well tolerated by most patients. It's not distressing to the patients. The patient can eat, can put his spectacles and watch television and read books and so on. The main advantage of the nasal cannula is the ability to achieve high concentration of inhaled oxygen in patients who have high minute ventilation. Simple or low flow or non-reservoir or the standard, all names for this mask, oxygen mask. This mask has a reservoir capacity of 150 to 250 ml, hence the risk of carbon dioxide rebreather. So the flow should be at least 5 liters per minute. These masks fit loosely to the face. They can deliver from 0.35 up to 0.6 FiO2 with flow from 5 to 10 liters per minute. The simple mask is not appropriate for delivery of FiO2 less than 35% because this requires the use of very low flow, which will lead to carbon dioxide rebreathing. The advantage and disadvantage of the simple mask. These standard masks can provide slightly higher concentration of FiO2 than nasal cannulas. However, this difference is small and insignificant. Generally, the face masks are considered to have the same drawbacks as the nasal cannula. Reservoir masks or masks with reservoir bags. If the addition of a reservoir bag to the standard face mask would increase the capacity of the oxygen reservoir by 600 to 1000 ml, depending on the size of the bag. If the reservoir bag is kept inflated, the patient will inhale only the gas contained in the bag. There are two types of mask reservoir bag devices. The first is called partial rebreathing, and the second is non-rebreathing. The first can deliver up to 0.8 FiO2 with oxygen flow between 8 to 10 liters per minute, while the non-rebreather can deliver FiO2 up to 1. Now, what is the idea of these reservoir masks? Now, as the patient exhales, the initial phase of expiration will return to the reservoir bag. And this initial phase is anatomical dead space which is devoid of carbon dioxide. As exhalation proceeds, the expiratory flow rate declines, and when it falls below the oxygen flow rate, exhaled gas can no longer return to the reservoir bag. So, the gas that is breathed is rich in oxygen and devoid of carbon dioxide. In the non-rebreathing reservoir mask, there is one-way valve. This one-way valve prevents any exhaled gas from returning to the reservoir bag. And these masks can permit delivery up to 1 FiO2. The advantage of reservoir mask is the delivery of high inspired fraction of oxygen, which may approach up to 1. They have this advantage of being tight fit, interfering with mouth feeding and nasointral tube. Also, aerosolized bronchodilator is not possible with these reservoir masks. Now the air entrainment Venturi, what's called Venti mask, Venturi mask, or high airflow oxygen entrainment. These masks receive initial oxygen in the low flow to pass through a narrow orifice. When they pass through this narrow orifice, they will have a high velocity stream of gas, producing what's called a viscous drag that pulls room air. Changing the size of this entrainment port will change the inspired FiO2 going to the patient. This mask can deliver FiO2 from 0.24 up to 0.6. The main advantage of these air entrainment Venturi masks or Venti masks is the delivery of constant FiO2, and they are very suitable for chronic obstructive pulmonary disease patients. In these patients, rely on the hypoxic drive, so it will be risky for them to start with high FiO2 because they may become hypoventilated. So we start the lowest FiO2 possible, which is 0.24, and we increase it gradually till hypoxemia is improved. Obstruction of the entrainment ports will increase the inspired fraction of oxygen. These masks have its advantage of the ability to deliver high inspired fraction of oxygen. Though, as we said before, they are suitable for chronic obstructive pulmonary disease patients. Now, what about the hazards of oxygen therapy? There are several factors that affect the hazard of oxygen therapy. Number one is the susceptibility of the patients. Not all patients the same. Number two, the inspired fraction of oxygen. Of course, zero point 0.4 differs from 0.8 differs from 100% oxygen. Third is the duration of exposure. Fourth, the age of the patient. Neonate has a characteristic complication known as renal fibroplasia, another complication known as bronchopulmonary dysplasia. And finally, the pressure of oxygen, is delivered at ambient pressure or it is hyperbaric. These are the hazards of oxygen therapy in general: absorption atelectasis, hypoventilation in COPD patients, chronic obstructive pulmonary disease, decreased systemic blood flow, ocular complications, and decreased mucociliary clearance. Again, tracheobronchitis, pulmonary toxicity, and it's called the dark side of oxygen therapy, and finally, bronchopulmonary dysplasia. Not finally. Also, we have fire hazards, we have complication related to the device itself as compression of the face, compression of the eye, the nose, and so on. And finally, unique complications related to hyperbaric oxygen, and these are the CNS complications. Now, what about oxygen and systemic blood flow? Oxygen has a tendency to reduce systemic blood flow, and this is because it produces vasoconstriction in all vascular beds except pulmonary, where it produces vasodilatation. It decreases the cardiac output by two mechanisms. First, reversal of the cardiac stimulatory effect of hypoxia. Second, it has a negative inotropic effect. Absorption atelectasis. Absorption atelectasis occur more with high FiO2 and in units with low ventilation perfusion relationship. It's explained by the following: removal of the nitrogen by high oxygen concentration will cause oxygen to be absorbed faster than it can be replaced by ventilation, with consequent loss of alveolar volume. And this is due to the high solubility of oxygen in the blood compared to nitrogen. It's to be noted that absorption atelectasis occur within minutes of oxygen administration. Ocular effects of oxygen therapy are the following: reversible constriction of the visual field of vision, progressive reversible myopia, delayed cataract formation, and finally the most popular one, retrolental fibroplasia in neonates. Let's take hints about retrolental fibroplasia in neonates, which was previously known as retinopathy of prematurity or ROP. It is defined as the formation of a membrane behind the lens, hence the name retrolental. High concentration of oxygen will promote new vessel growth that extends beyond the retina into the vitreous humor. These vessels are prone to dilatation and rupture, leading to vitreous and retinal hemorrhage, fibrosis, adhesions, causing retinal detachment and blindness. The main risk factor in retroretinal fibroplasia is prematurity. It occurs in neonates less than 30 weeks or less than 1.5 kilograms exposed to high FiO2. Restricting oxygen will not necessarily reduce the rate of progression once it begins. Oxygen concentration more than 40% for 1 to 2 days after birth may be implicated. Neonates who develop retroretinal fibroplasia have arterial pressure of oxygen more than 80 mmHg for more than 6 hours cause progressive damage. So, SpO2 of 90 is aimed for. Bronchopulmonary dysplasia occurs in mechanically ventilated children, namely premature neonates. It occurs in 10 to 20% of those with acute respiratory distress syndrome and is defined as increase in oxygen demand for more than 30 days in the presence of typical radiological changes. Bronchopulmonary dysplasia is related to the severity of respiratory distress syndrome, the degree of prematurity, the high and prolonged oxygen concentration. It improves with age and alveolar growth, improves respiratory function and reserve. As we said before, the characteristic radiological findings in bronchopulmonary dysplasia, which is diffuse, defined reticular ground glass appearance of the lung. Now we come to what's called pulmotoxicity, which is the most risky complications, and which some people call the dark side of oxygen therapy. Factors related to pulmotoxicity are: number one, it is the oxygen partial pressure, not the percentage. We mean people at high altitude be exposed to less pressure, hence less risk. So at 100% oxygen, at pressure of 250 torr, 2 to 4 weeks can be tolerated. Which was the case on the ambient pressure. Also, it is the alveolar oxygen rather than the arterial pressure of oxygen which is responsible for toxicity. Second, the duration. Of course, toxicity is directly proportional to the duration of oxygen exposure. And finally, susceptibility and illness. Because critical ill patients and patients in the ICU may be more prone to such toxicity due to deficiency in oxygen-free radicals, as we shall say later on. The free radical theory is the most accepted theory that explains the mechanism of oxygen toxicity. Oxygen metabolism will produce free oxygen radicals. These are the superoxide radical, the H2O2, what's called hydrogen peroxide, and the OH negative is called the hydroxyl free radical. All are powerful oxidants capable of damaging cell membranes, denaturing proteins, and breaking DNA into strands. The hydroxyl free radical is the most reactive molecule known in biochemistry The activation of granulocytes as a part of the inflammatory process involves up to 20-fold increase in oxygen consumption. This is known as respiratory burst, and the purpose is to produce toxin oxygen metabolites which are stored in the cytoplasmic granules. And these are a part of the inflammatory process or inflammatory response that can damage and destroy individual organisms. They also can damage tissues of the host if inadequate antioxidant is not present. These oxygen-free radicals are implicated in the acute respiratory distress syndrome and in the systemic inflammatory response syndrome, what's called SIRS. These are the harmful effects of free radicals. They are capable of lipid peroxidation in cell membranes. They inactivate cellular enzymes. They will inhibit nucleic acids. And finally, they will inhibit protein synthesis. This diagram shows the metabolite of oxygen and the free radical scavenger, the enzymatic free radical scavengers are shown in the figure. But the red color are the free radicals, the superoxide oxygen, and the hydrogen peroxide, and the hydroxide free radical. The enzymatic free radical scavengers, which are protectors, are seen in the figure, namely superoxide dismutase, the catalase, and glutathione peroxidase. Now, what are the antioxidants? Antioxidants are either enzymatic and others non-enzymatic, namely vitamin A or alpha tocopherol present in cell membranes, vitamin C or ascorbic acid extracellular in the lung, the ceruloplasmin and transferrin, and they limit free iron in the plasma, and finally the selenium. Oxygen stress is a condition of unopposed biological oxidation. We mean there is an imbalance between the production of oxygen-free radicals and antioxidants. This imbalance is in favor of the oxygen-free radicals. Hence the name oxidant stress. Oxygen toxicity can also occur due to cellular metabolic alteration or enzyme inhibition. It's not mediated by free radicals. Now, what is the FiO2 toxic? 0.6 exposure for 36 to 48 hours, 0.8 for more than 24 hours, while 1 or 100% more than 12 hours, while half FiO2 is safe for unlimited period. However, due to lack of the antioxidants in the critical patients, it's considered that any FiO2 above normal or above room air or above 0.21 can represent toxic exposure in the ICU. What's the pathology of pulmonary toxicity? It is that of acute respiratory distress syndrome. Of course, it will be preceded by tracheobronchitis, and the condition will progress up to respiratory failure. CNS oxygen toxicity. This occurs only with hyperbaric oxygen, as in divers. Symptoms occur above a threshold of 150 kilopascal. Visual changes, particularly tunnel vision, tinnitus, nausea, twitching, irritability, dizziness, tonic-clonic seizures, and finally, unconsciousness. By the way, these are the indications of hyperbaric oxygen therapy. The most popular, the most famous indication is carbon monoxide poisoning. Others are decompression sickness, respiratory distress in neonates, anaerobic infections as gas gangrene caused by Clostridium willi, refractory chronic osteomyelitis, infected superficial burns, and finally sensitized tumors to radiotherapy. Now we have some questions just for refreshment. Some of the complications of the therapy at ambient pressure. What is the complication unique to hyperbaric oxygen? Of course, the CNS complication. What is the name of the oxygen toxicity theory? It's called free radical oxygen theory. The oxygen free radicals are superoxide, hydrogen peroxide, and hydroxide free radical. The enzymatic free radical scavengers are catalase, superoxide dismutase, and glutathione peroxidase. What about the relation between glutathione and N-acetylcysteine? N-acetylcysteine is a glutathione analog capable of crossing cell membranes and enhancing the intracellular glutathione activity. And this is the mechanism of the beneficial effects of an N-acetylcysteine in the acetaminophen toxicity. Non-enzymatic free radical scavengers are catalase, glutathione peroxidase, and superoxide dismutase. Why there is little free iron in the plasma? Because free iron is pro-oxidant. The safe unlimited duration of Fi2 in healthy person is half, but in critically ill patients it is 0.21, similar to room air, because simply these patients may have deficient amount of oxygen-free radicals. The low-flow oxygen therapy devices are nasal cannula or nasal sponge, simple mask, and the reservoir masks. Fixed performance devices are the bag mask valve and the venti mask or high airflow oxygen in train. The oxygen device therapy that can deliver up to 100% oxygen with a non-rebreathing reservoir mask. The maximum flow delivered with the nasal cannula is 5 to 6 liters per minute. The disease in which the venti masks are used is the chronic obstructive pulmonary disease. To produce a controlled oxygen therapy, difference between partial rebreather and non-rebreather. In non-rebreather, there is a one-way valve that prevents the exhaled air from going in the reservoir bag. The simple mask is not appropriate to deliver less than 0.35 FiO2 because delivery of this low FiO2 requires the use of low flow of oxygen, which will lead to carbon dioxide rebreathing, because the reservoir bag must have room of 150 ml to 250, contrary to the cannula which has a 50 ml only.